introduce my dear friend, one of the very eminent phlebologists, not just in Germany, but all over the world. Professor Tobias Hirsch is a specialist in internal medicine and angiology, board member of the Professional Association of Phlebology. He has been invited as a speaker and lecturer in many international vascular conferences in Germany, in Europe, in United Kingdom, and United States. In 2020, Tobias Hirsch has chaired the 62nd International Annual Conference of German Society of Phlebology. He is a board member of both German Society of Phlebology and Professional Association of German Phlebologists, and he's also the executive board member of European College of Phlebology. I always enjoy your research, always enjoy your lecture. We are all ears, your great presentation, Tobias.
Dear Dr. Mohamed, thank you so much for this kind introduction. Can you already see my slide?
Yes, I can see it very well.
So, ladies and gentlemen, and now I'm very happy to add some information and news about one of the most important instruments we have in phlebology, and that's compression therapy. My aim is to provide information about current developments in this field and to explain how I use it. Despite all the innovations, this type of treatment has a long history. These are my disclosures. I took this photo in Klatovy, Bohemia, in the Czech Republic. These are monks who were buried 350 years ago, excellent preserved mummies. And I made a great discovery here. This monk definitely suffered from lymphedema, I think. And what type of treatment did he receive? The answer is bandages, compression bandages. I was totally blown away when I saw that. But let's talk about contemporary compression materials. This is what we use today. Compression bandages like this. We have run-of-the-mill compression stockings, and the most up-to-date device on the market are medical adaptive compression systems. When we talk about compression bandaging, we have to be aware that this is often the reality. The road to hell is paved with good intentions, but this is reality. This is what we see when the patient comes to our practice treated with bandages. And this is a big problem because so we have more damage than benefit for the patient. Compression bandaging is a kind of a handcraft, an art form. It has to be applied by a very skilled physiotherapist or nurse or doctor, and includes padding and toe bandages, so that I will provide compression throughout the day. Only if I can provide all these fittings, it's possible to make a proper treatment. It's a difficult technique, and only a small number of compression bandages is still working when we see the patient in the evening. Medical compression stockings. We distinguish between circular knitting stockings for chronic venous disease, varicose veins, and also venous ulcer, and flat knitted compression stockings, what we use for lymphedema and lipedema and for special calibers. At the end, with those two types of knitwear, it is possible to treat, to apply a proper compression treatment with all the patients. Usually a seam on the back side indicates this is flat knit, as you can see on the right-hand side here. My first tip for you is use and prescribe donning aids. They make life easier for your patients and yourself, and they increase your patient's compliance significantly. Even a simple rubber glove can be a game changer. The point is, the best prescription doesn't work if the stocking is kept in the cupboard. It has to be worn, and so use these types of several donning aids and ask the patient which one is the best for him to use. Here you see the most topical development, adaptive compression systems. I will come back to them later because I think this is a real revolution, and this is not that common at the moment as it should be. In this table, you see the pros and cons of each compression medium. CB means compression bandages. Advantages are they are suitable for all types of edema, and they are very cost effective. Disadvantages are a healthcare professional is required. This is not possible to manage for the patient himself. Self-management is difficult, and they slip during the day. What about compression stockings, MCS, medical compression stockings? They apply standardized compression. They have an optimal fit, and you can divide into stockings and shorts, capris, and you have circular and flat knitwear. And so you have a great variety of options to treat with your patients. The disadvantages are they only are useful after a decongestive therapy. You cannot treat your patient with an acute DVT with a compression stocking, because this stocking won't fit after the edema has been decongested. And then we have maybe a reimbursement problem. There are costs, especially flat knitted medical compression stockings and capris and shorts, and are quite expensive. And then we have the new adaptive compression devices. They make self-management easy. They are suitable for all types of edema, and they also apply standardized compression. I don't see a lot of disadvantages in Germany. The reimbursement at the moment is a little bit difficult, and so you have to wait to get the permission to prescribe that. But they are not more expensive than stockings, and if you have to apply a proper bandaging, it is also not that cheap as the people of the health insurance companies think. So keep in mind, we have these adaptive compression devices. The next thing is to talk about is, what about compression classes? We distinguish into 4 different classes, and it's quite easily to work with because different classes are appropriate for different disease, to make it easy. So a light compression stocking of class 1 with a pressure of 18 to 21 millimeters of mercury is a proper treatment for a chronic venous disease, for varicose veins, and it's sufficient in 80% of cases. A class 2 stocking, especially a class 2 round wound stocking, is the instrument you need for post-thrombotic syndrome, what you need for the first 3 months after DVT, but also for lipedema and lymphedema. But in these cases, you better use flat knit. But in most of the cases, class 2 is appropriate, but you can combine with other tools, and you can also use a higher compression class, especially for severe lymphedema. In a lot of cases, you need a compression class 3, what means 30 to 46 millimeters of mercury. How high is this? It seems to be a very high pressure, but on the other hand, in a standing position, the vein pressure in an insufficient vein at the ankle is around 70 to 80 millimeters of mercury. So it makes the compression of 40 millimeters of mercury relative. What do the What do the guidelines recommend? There are 3 papers I would like to draw your attention to. You see there is one current paper about the indications for medical compression stockings, one about the risks and contraindications, and then we have the 2022 guidelines of the European Society of Vascular Surgery. I start with the indications for medical compression stockings, and the authors of this paper conclude that there are 14 recommendations. They improve venous symptoms. They are appropriate for the prevention and improvement of venous edema, improvement of skin changes. They improve venous ulcer healing. They prevent of venous ulcer recurrence, and there is an improvement of early side effects after venous intervention. And there is also an effect on the development of a post-thrombotic syndrome. And I have one table from these European guidelines I want to show you. In the green line, you see that we have a class 1 recommendation for elastic compression stockings with over 50 millimeters of mercury for venous symptoms. We have a class 1B recommendation for edema treatment with higher class, 20 to 40 millimeters, that's class 2. And we have a class 1 recommendation also for the treatment of skin changes. And on the right-hand side, you see the most important recommendations. It is class 1A recommendation for ulcer treatment. So we always think about early endovenous treatment of varicose veins, and we spend a lot of money for wound dressings, and then we observe that there is no proper compression on these patients, and so we cannot be successful. You see, class 1A, it's the strongest recommendation you can get for compression therapy in leg ulcers. And the next thing is there are only few contraindications. Contraindications for this is the conclusion of this text. Contraindications are only severe peripheral arterial obstructive disease. Severe, that means we have a pressure below 70 millimeters of mercury maximum. This is severe. Another hard contraindication is severe cardiac insufficiency. In an outpatient setting, you only will see a severe cardiac insufficiency in very, very, very rare cases. Severe insufficiency means NIHA 3 and 4, patients that are unable to do any work, patients who suffer from dyspnea when sitting in their bed. These are patients with severe cardiac insufficiency. If they reach your practice, they probably will not suffer from severe cardiac insufficiency. And then it's always clear if there is an allergy to the compression material, you must not apply this type. Let's come to the practical approach. This is Alf. We talked about contraindications. He's a road builder. He has to work very strong and he loves his profession. And he has lymphedema on his right leg. And he also suffers from arterial obstructive disease. And he has this iliaco-femoral-popliteal bypass. On the right-hand side, you see the scars after this bypass. on the image in the middle, you can see that there is a veritable lymphedema. A lymphedema as a following this surgery, but this is what can happen. Now we have observed the patient, and he also has an ABI of 0.74 on his right leg. He has this this bypass, but the long-term result is not that good. On the right-hand side, you see that there are very bad arterial signals. But we have to treat both. So he is able to work and he wants to work. And so we have to help him. And so what we did is we started with decongestion of the lymphedema. And you can see that we could decrease the leg volume on his right leg. And we did it with a compression stocking. We used a flat knit, but class 1 compression stocking. It's clear for lymphedema, a better way would be to treat him with the class 2 stocking, but because of these changes and this bypass, we decided to use class 1, and you can also see that the stocking doesn't belongs to the knee heel, because as a result of the scars, it was very painful for him in this era. He didn't accept a stocking at the knee, and that's why we had to do a shorter one. But we could manage that with a shorter class 2 flat knitted compression stocking. You have to vary in order to do the best for your patient. Here we have another case of a 52-year-old man who is suffering from prostate cancer and a veritable lymphedema of the right leg following oncological surgery. The recommended treatment options are manual lymphatic drainage, compression bandages, flat knitted garments, movement, skincare. We all know about that, but on the other hand, in the real world, he has to work 40 hours a week. He has family, and probably he has hobbies. This requires self-management strategies. And this is what we wanted to find out with a trial. I want to present you on one of the new adaptive compression devices. We conducted a multi-center study in 4 centers in Germany and Poland, and these are the preliminary results that we up to now we have already published. The primary endpoint was the independent handling of the new MAC system in the time frame from start till 6 weeks, and secondary endpoints were patient satisfaction and relief from discomfort, reduction of the clinical edema, and a volume of the lower limb. And we try to identify cost savings resulting from self-management over the need for an HCP service. Pitting edema was the most important inclusion criteria. Here you see the disease entities that were included in the baseline characteristics. The BMI and the waist to height ratio indicate that the majority of the included individuals were obese. And these are typical representatives of our study group. And I'm sure that you know this type of patient, and probably you see them also in your clinic every day. We conducted interviews to obtain the clinical scores and measured the leg circumferences and volumes using the so-called leg reader device. It is a device that enables you to measure the diameters of the leg contactless. It was very important as we conducted this trial during the pandemic, and so it was nice to be able to measure the circumference without touching your patient too much. And these are the results. The rep was fitted correctly by 91% of patients within the first week of use. More than 90% considered the rep to be very or fairly easy to put on. And more than 90% considered the rep to be very or fairly easy to put on. What about patient satisfaction? Green means satisfied or quite satisfied. Wear comfort after 6 weeks. Green again means it's comfortable or rather comfortable. And in terms of further use, 96% continued wearing the device always or intermittently beyond 6 weeks. Once I have presented the results of the surveys, I will show you the results of the lymph ICF score and the measurement results. We can see clear and significant decrease in complaints in all categories: physical, mental, household, mobility, and social. This diagram indicates the degree of volume reduction during 6 weeks of use. And here you see that it works for all types of edema we included. And from the last graph, we learn that there is a higher effect in patients who didn't undergo compression therapy prior to using the rep. But the message is use the right compression tool. This is what we can see frequently. A 58-year-old lady suffering from lipedema, obese, and also secondary lymphedema. And in this case, circular knit does not work. So you need to decongest her, and you can use reps for decongestion. And at the end, you can prescribe a proper knitwear, and that's flat knit in this case. Let's dive into another very realistic case from last week. Here we have a 72-year-old gentleman who has been suffering from a venous ulcer on his left leg since February 2022. We see severe reflux in the light reflex rheography. And this is our treatment plan. In addition to wound care and thermal ablation of the grade GSV, we performed a decongestion using ICP and a rep system. And that's very interesting. I want to recommend this paper from Dr. Mendoza, which came out during the last week. She could bring the evidence that manual lymphatic drainage can be replaced by intermittent pneumatic compression in lymphedema during the maintenance therapy. This is a very, very topical paper you can find in VASA, and I want to recommend it. And thank you so much, Erika, for this. So, and this is what we do. Once we have decongested using ICP, we use a rep. We use the Coolflex rep, which is more or less like a tube. And you see my nurse applying this. And it's very easy. It is not a rep because we don't use these Velcro occluders. We use hooks, and you see seams, and these white seams are to indicate which compression is applied, and 2 lines means we have a compression class 2. And it took my nurse no longer than 1 minute for applying this wrap. And this is what also is possible for the patient himself, as we could show in our ACROE trial. I want to conclude. Compression therapy is the basis of phlebological and lymphological therapy. There are only few absolute contraindications. Effect and compliance can be influenced by the selection of the compression medium, the material, and the compression class. And don't forget, keep in mind, compression class 1 works very well. Donning aids should be considered to improve self-management, and adaptive compression systems, so-called wraps, make life easier. MACs give patients with chronic leg edema a high degree of independence. The patients are satisfied and compliant with wearing MACs, as we could indicate with our ACROE trial. And the devices are especially suitable for patients with edema related to obesity. They are appropriate for a very, very large number of patients. And improving self-management helps to cut down on healthcare costs. It is able to save your time in the practice and also for the patient himself. So thank you very much.
Thank you so much, Dr. Tobias. Really, really very interesting outcomes from your experience. I was actually really happy that we're part of the ACROE study. And here I'm also to the audience. If you would like to have the details about the ACROE study, of course, you can reach us, Dr. Tobias, but also our team from Service Group, who is visiting you in the clinic, can also provide you a lot of information about the study and the outcomes. It was always a pleasure, and also like one of our competencies that we deliver our knowledge in terms of compression therapy application with the expert. So we like to work closely with the eminent and the professional expert like Dr. Tobias Hirsch to bring to life solutions can really help the patient to improve the outcome. So we look at the topic as more like a multidisciplinary approach to bring different stakeholder knowledge together and to make sure that's all at the end of the benefit of our patient. I will share now on the chat also from my side different links to keep you updated with subscribing to our newsletters or following our LinkedIn page or YouTube channel. But also, again, please keep in mind, training and education is what we can actually deliver the best. Our team are very well trained and willing to join you in your clinic with your nurses, with your staff, to make sure that everyone knows how it works, how we can apply the compression stocking, how also the patient can take care of their legs, of their skin, different donning devices and donning aids to improve the outcomes. So use the team, use them in terms of educating your patient or your staff as well. So I think that was also one comment from my side. Again, thanks so much, Dr. Tobias. And now to Dr. Omar Elfarok.
Okay, thank you very much, Dr. Tobias, for the best presentation I have ever seen on compression. And thank you for letting us know the MAC system for the lower limb. I have a good question from Erika. Please go ahead, Erika.
Yes, Tobias. As always, perfect presentation. You said something I didn't. You said that
we can't hear you very well if you
can you put the mic?
Yeah. Sorry, my mic is gone. Sorry.
Oh, that's it. Yeah, that's much better.
As always, Tobias, wonderful presentation. Thank you. Very clear. But I disagree in one point, and I want to ask what you mean. You said that the bandages are cheap. And I think this is not correct. Because if you take double layer bandages, which are in my eyes, this cohesive, the first layer and the second adhesive, so that it can stay 2 or 3 days, I made a calculation on the cost of 2 or 3 weeks of these bandages and then stockings versus an adaptive compression device. And if you include the material and the nurse going home to the patient and so on, it is cheaper to put an adaptive device from the first moment. The problem, at least in Germany, it is I mean, the advantage is the public healthcare system pays for it, but it takes the administration 4 weeks to allow the patient to get it. So the gap in between, we have to bandage, and this is completely stupid. But if we could treat without money, the best thing would be giving the adaptive thing just from the beginning, because this is really cost effective.
Excellent.
I completely agree.
Comment? Yeah.
I agree. I completely agree because to apply a multi-layer bandage is not the same like apply one wounded fabrics. Yeah. Yes, this is the problem. But this is very difficult to teach the health insurance companies. They only see that one bandage costs about 20 or 30 euros, and you need maybe 4 of them, and they compare that with an MAC, but they don't compare proper treatment with proper treatment. If you compare proper treatment, you have the first thing is you need manpower. You need this healthcare professional who is able to apply such a multi-layer bandage, and so you cannot compare that. It's a lot of work for us to teach them about these news. Yes, but yes. We have already started with this.
Excellent, very good. You know, surprisingly, I was reading a book about a month ago about the vascular diseases in animal. Surprisingly, giraffe, which is born standing and die standing, so standing 100% of the time, will never get venous ulcer. It's not been recorded, and they are standing the whole day. And the beauty about it, the author have done the biological design of the skin. It is very, very near to your MAC system. So this is really surprising, because it seems this is a solution. You got different amount of pressure into different amount of the leg being compressed in the proper way. The giraffe skin is formed of 120 layers. That is why they never get venous ulcer. So I'm really excited about your new MAC system and the support from Dr. Mahmoud, and hopefully we'll have it in the market in Egypt, hopefully very soon. Let me take a question from the attendee. There is a question from Armia Sargeus. What are the contraindications for compression bandage? I think you mentioned in your slide, but I think they all want to know if anything else other than severe arterial ischemia, is there any other contraindication and allergy?
The contraindication doesn't depend on the device you use. The effect of the bandage, of a well-applied bandage, and an MAC and a stocking is always the same. But there is no Swiss Army tool where one fits for all, and so you have to use the best one for your special patient. But then you have to think about a possible contraindication. And if your patient has severe heart insufficiency, you cannot apply a high degree compression using bandages, neither using other types of compression devices. On the other hand, you are able to apply a gentle compression, fewer compression with a bandage. A bandage can be in your room, and you can immediately start, but probably the next day you have to think about the further treatment of your patient, as we all have to be clear that bandages are only a one-day solution, or the partner of your patient is able to apply that the next day again. But the contraindication does not depend on the device or the device you use. Yes.
Excellent. Thank you very much. We got another question from Dr. Nasser Al-Zahari.
I have a comment on that.
Please.
Yes.
Yeah, please.
you have, for example, the most difficult situation, as Tobias pointed out, is the compression when you have an ulceration, because we have a 1A class. We can be sure that the ulcers need to be compressed. And if you have a mixed ulcer with arterial problems, I make two things. First, I use, there are compression stockings for ulcer patients, where is a very, very slight compression under stocking and a normal compression stocking. And I start convincing the patient that he can wear it with a very, very thin understocking, which is like 10 millimeters mercury of pressure, which is nearly nothing. And the second thing I do is I apply manual lymphatic drainage, because this decongests the tissue and allows a better arterial perfusion. In the moment that the edema leaves for the manual compression, manual lymphatic drainage, you have less pressure in the leg, and then the stocking is better tolerated. And you always should remember that patients with nearly amputation of the leg for arterial problems, they shall be given intermittent compression, because this improves the arterial perfusion also. So you can use this intermittent compression devices to reduce the edema, helping the arteries in the same situation. So I completely agree with Tobias that you cannot say it's impossible to use compression, because you normally can do something if there is edema. Sorry.
So no, thank you very much for your enlightening comment. So a question from Dr. Nasser Al-Zahari. What is the duration of compression post-varicose vein ablation and post-acute DVT? How many days would you give compression, Tobias?
After varicose vein treatment, we conducted a trial, a synchronous trial, where the endpoint was the ablation, the additional ablation of the AASV, but we also observed the effect of compression, and we had the best results when patients received compression over 2 weeks after the treatment. A longer compression treatment after the ablation had no additional benefit. And so this finding, we included more than 1,000 patients into this trial. And the consequence for me was that from then, I recommended my patients to wear the stockings for 2 weeks instead of 1 week. Before I did this, I recommended them to wear the stocking for 1 week. And since we have known that from our own trial, and I trust in the results of our own trial, I always recommend them to use them for 2 weeks. But on the other hand, I'm a compressioner. I prescribe a lot of stockings, and we see a lot of patients who don't suffer from varicose veins, who never have had a DVT or post-thrombotic syndrome or something like that, but they work as hairdressers, nurses, teachers, or something like that, and they come back from home and they have problems, they have complaints. And for those patients, these patients don't need laser or radio frequency or whatever. They need proper compression. And in my case, we then prescribe class 1 below the knee stocking with a great effect. This is what I would recommend. I recommend 2 weeks of compression after endovenous treatment.
And your comment, Erika? Yeah, please. Yes,
when it comes to DVT treatment, DVT is another very important point. For DVT treatment, we know that class 2 is superior over class 1 stocking. And the most important point is to start as early as possible. If you have made the diagnosis of DVT, you have to start with the compression treatment with the intention of a better outcome with respect to post-thrombotic syndrome. And then after 3 months, there is no additional effect. Then the length of treatment depends on the complaints the patient has. If he has no longer complaints after 3 months, no edema, no skin changes. You can stop treating them with compression. But if you see the best results you have, and he says, yeah, but in the evening my leg is swollen, then you have a device in when using compressions.
Okay, and your comment, Erika, how long do you keep?
Nothing to add. It's perfect. Tobias is it's completely my line. Yes. Completely.
Okay, that is great.
One line.
Yeah. Do we have more time for any more question, Dr. Mahmoud, or?
I think we can have like one last question, and then we would like to have also 1 minute take-home message from each speaker. But just to last one comment from my side, I think we all always following Dr. Tobias' recommendation when it comes to compression application. And we fully agree also from our side that it all depends on the complaints and symptoms. So there is no like time we said, okay, the patient should stop using the compression now or should use it for many months. It depends, of course, on the progress, but also other factors of the lifestyle of the patient. Exactly as Dr. Tobias mentioned, that some of the people have lifestyle or work profession requires standing or sitting the whole day, and that's also a high risk factor. And in this case, of course, eventually you will have some issues. So either as a prophylaxis or as a treatment, the compression was always depend on the symptoms, but also on the complaints from the patient themselves.
Absolutely, absolutely agree. And I was told that we have hundreds of people on the Facebook watching our webinar, which is really exciting. So let me take opportunity to fire one of the last question. If you have a clinic, Tobias, and you want to put 3 compression devices that you commonly use that form 90% of your practice, what 3 devices will you keep on your clinic, or you have everything in your clinic?
I have everything in my clinic, but to be honest, most of the devices we use are the Coolflex MACs. But this is because we have conducted this trial, and it's very easy to apply, and we have a very good compliance with the patients. There are patients who are completely decongested and have already a prescription of stockings, but they come to me and tell me, no, I wear this this Coolflex because it's easier to off and on. That's the point. Especially we have such a big number of obese patients, and they are suffering from edema. And for them, it's very easy to slip into this device. Yes, but this is most of our prescriptions are MCS stockings. But for the acute treatment, I would always use this.
Okay. What about you, Erika? You have everything also in your clinic?
I have no adaptive devices in my clinic because we are not allowed to have them and to don them to the patients. But I have bandages for the acute situation. I have them here, and I have like stockings and flat knitted around. But if I have a pitting edema, I bandage them. I look at them 2 or 3 days later and then convert to the stockings. I would use far more adaptive devices, but I have the problem that the moment they are allowed to be given to the patient by the healthcare insurance, the problem is gone because they are bandaged and the edema is gone. So if I could choose like I wanted, I would use them far more often, the adaptive devices.
Excellent. So let me take the chance to have one final, let us say, grand summary of your presentation and your learning objective. We learned a lot from you, Erika, and from you, Tobias, today. I'm really very, very happy about this knowledge, which serve not 100, it can serve millions of patients. As we are getting more and more older, this is extremely common situation. So if you can summarize to us, Erika, what you like the message to give us today, and after that, Tobias, and then I'll give the mic after that to Dr. Mees.
Okay, thank you so much for organizing in the first case and for inviting. Yes, my topic is you have to be sure when you make a venous investigation that you use the proper method to elicit the blood flow, and if you should use Valsalva and compression and some dynamic maneuver like the Paraná pushing the patient or toe elevation. And if you are in doubt, you can make this orthostatic maneuver, and you have to be very keen in defining where the reflux comes from and where it drains, perforating veins and so on. And as to my eyes, I'm sometimes called the queen of ultrasound because it's like my life, but I would never treat a patient based on the duplex result. I would only treat the patient based on the clinics the patient has and the wishes the patient has. And I use the duplex to have a tool to prepare my intervention the best possible fitting to the patient, but not to decide that I shall treat them. This is my... Yes.
Excellent. That's a beautiful summary of your presentation. And Tobias? Yeah.
Once you have done a proper diagnostic using duplex ultrasound, and this is the heart of our diagnostic, you can immediately start treating your patients with one thing, and this is compression. Compression is a great standalone therapy for all phlebological patients, and it's a perfect add-on therapy for all the patients who need other treatments, from wound dressings over deep venous thrombosis and varicose veins. Compression therapy fits always.